Polyarteritis nodosa, PAN, is a rare systemic vasculitis that causes inflammation in medium-sized arteries, damaging multiple organs. This video will explain the pathophysiology, clinical manifestations, diagnostic approach, and treatment strategies of PAN, offering a comprehensive understanding for medical professionals. Polyarteritis nodosa is classified as a medium-sized vasculitis, along with other conditions such as Kawasaki disease, giant cell arteritis, and Takayasu arteritis. The pathophysiology of PAN involves immune-mediated inflammation of the arterial walls, leading to segmental necrotizing vasculitis. The exact etiology remains unknown, but it is believed to be a result of an abnormal immune response triggered by various factors such as infections, drugs, or malignancies. The characteristic histopathological findings include transmural necrotizing inflammation with fibrinoid necrosis. Polyarteritis nodosa involves the immune system, specifically T cells and monocytes. They release pro-inflammatory cytokines, leading to recruitment and activation of inflammatory cells. Immune complexes are also deposited in arterial walls, causing vascular damage. Inflammation markers play a crucial role in diagnosing and monitoring the disease activity of polyarteritis nodosa. Laboratory investigations often reveal elevated erythrocyte sedimentation rate, ESR, and C-reactive protein, CRP, levels, indicating the presence of systemic inflammation. Furthermore, the levels of circulating immune complexes, such as rheumatoid factor and complement components, can assist in the diagnosis and monitoring of disease progression. Polyarteritis nodosa can affect multiple organ systems, leading to a wide range of clinical manifestations. The most commonly involved organs include the skin, joints, peripheral nervous system, gastrointestinal tract, and kidneys. Patients may present with nonspecific symptoms, such as fever, fatigue, and weight loss. Skin manifestations can vary from palpable purpura, livedo reticularis, to ulcers. Arthralgia and myalgia are common musculoskeletal complaints. Peripheral neuropathy, abdominal pain, and gastrointestinal bleeding may also occur. Renal involvement is a significant concern, leading to hypertension, proteinuria, and renal insufficiency. Accurate and timely diagnosis of polyarteritis nodosa is crucial for initiating appropriate treatment. The diagnostic approach involves a combination of clinical assessment, laboratory investigations, imaging studies, and histopathological examination. The American College of Rheumatology, ACR, has established criteria for diagnosing PAN, which includes the presence of characteristic histopathological findings or angiographic abnormalities, as well as the absence of alternative explanations for the clinical manifestations. Polyarteritis nodosa shares clinical features with other vasculitides and systemic diseases, making the differential diagnosis challenging. Conditions that need to be considered include microscopic polyangiitis, granulomatosis with polyangiitis, formerly Wegener's granulomatosis, eosinophilic granulomatosis with polyangiitis, formerly Churg-Strauss syndrome, and systemic lupus erythematosus. Distinguishing between these conditions requires careful evaluation of the clinical presentation, laboratory findings, and imaging studies. Polyarteritis nodosa can affect various organs, and the extent of organ involvement significantly impacts the prognosis and treatment approach. The kidneys are commonly affected, leading to renal artery stenosis, glomerulonephritis, and ultimately renal failure if left untreated. Other organs, such as the heart, lungs, gastrointestinal tract, central nervous system, and musculoskeletal system, may also be affected to varying degrees. Prompt recognition and management of organ involvement are essential to prevent irreversible damage. The primary goals of treating polyarteritis nodosa are controlling inflammation, preventing organ damage, and improving the overall prognosis. The mainstay of treatment involves immunosuppressive therapy, aiming to suppress the abnormal immune response. Corticosteroids, such as prednisone, are typically initiated, often in conjunction with other immunosuppressive agents, such as cyclophosphamide or methotrexate. In cases associated with hepatitis B virus infection, antiviral therapy targeting the viral replication is also crucial. Additionally, supportive measures, such as blood pressure control, pain management, and nutritional support, are integral components of comprehensive care. The prognosis of polyarteritis nodosa varies depending on several factors, including the extent and severity of organ involvement, response to treatment, and the presence of complications. Prompt initiation of immunosuppressive therapy has been associated with improved outcomes. However, relapses can occur, requiring ongoing monitoring and adjustments to the treatment regimen. Regular follow-up visits, including clinical assessments, laboratory investigations, and imaging studies, are necessary to monitor disease activity, manage complications, and guide treatment decisions. One important association seen in polyarteritis nodosa is its strong link with hepatitis B virus, HBV, infection. Approximately 30 to 40% of PAN cases are associated with chronic HBV infection. The exact mechanisms underlying the association remain unclear, but it is believed that viral antigens trigger an immune response leading to the development of PAN. Screening for HBV infection is crucial in all patients diagnosed with PAN, as it impacts the treatment approach and prognosis. Renal involvement is a significant complication of polyarteritis nodosa, and its pathology can vary. On renal biopsy, characteristic findings include segmental necrotizing arteritis, fibrinoid necrosis, and inflammatory cell infiltration in the arterial walls. Glomerular abnormalities, such as focal segmental glomerulosclerosis and crescentic glomerulonephritis, may also be observed. Recognition of renal pathology is essential for confirming the diagnosis, assessing disease severity, and guiding therapeutic interventions. Neurological complications can occur in polyarteritis nodosa due to the involvement of arteries supplying the central nervous system. Ischemic stroke, transient ischemic attacks, peripheral neuropathy, and mononeuritis multiplex are some of the neurological manifestations observed. The severity and progression of neurological complications can vary, requiring a multidisciplinary approach involving neurologists, nephrologists, and rheumatologists to optimize management. Polyarteritis nodosa is a complex vasculitis with immune-mediated arterial inflammation. Accurate diagnosis involves clinical assessment, lab investigations, imaging, histopathology, and management includes immunosuppression, supportive care, and regular follow-up. PAN's association with hepatitis B underscores the need for comprehensive evaluation, and expanding our knowledge can improve patient outcomes.